I wanted to pick your brain a little bit. As you mentioned in our earlier conversation, there was a lot of good data. And of course, two of the biggest studies examined SGLT2 inhibitors
Yes,
with emperor reduced and DAPA-CKD.
exactly.
There's most of the time people talk about these agents as a class. I think right now, empagliflozin and dapagliflozin have really sort of set themselves apart. What kind of excitement is there around the SGLT2 class now that we have all of this definitive data on it?
Well, the story of SGLT2 inhibitors um, is amazing. I mean, these were drugs that were developed for the treatment of diabetes. And all they were supposed to do was lower blood glucose. And the magnitude of that effect was not particularly impressive. Other anti-diabetic drugs had greater effects to lower blood glucose. And what these drugs did was they just seemed to increase the excretion of glucose in the urine. And boy, that didn't seem like a very interesting mechanism. And, people sort of didn't necessarily give them a great deal of attention. But as you know, years ago, in 2008, the US FDA mandated that all new anti-diabetic drugs had to do cardiovascular outcome trials. And in many of these trials, the anti-diabetic drug lowered glucose and didn't affect cardiovascular events or renal events. There were some positive signals with GLP-1 receptor agonists, but when the data came in on SGLT2 inhibitors, we saw in trial after trial in diabetes, in type 2 diabetes, two very distinct positive indicators. One, a major effect to reduce heart failure hospitalizations, and two, a major effect to reduce the progression of renal disease and the risk of serious adverse renal events. And we had never seen that with an anti-diabetic drug after only 1, 2, 3 years of treatment. So we thought, well, okay, we have one SGLT2 inhibitor trial that shows protection of the heart and the kidneys. Then we have a second, then we have a third. And then people realize, well, these benefits really don't have anything to do with the effect of these drugs on glucose. These drugs have a direct effect to protect cardiac and kidney cells from stress, injury, and death. And so they're organ protective of two organs that are really commonly stressed, not only in diabetes, but chronic heart failure, chronic kidney disease. So many of us thought, well, let's look at whether these drugs work in people who don't have diabetes. And we looked at heart failure with a reduced ejection fraction with or without diabetes. The DAPA-HF investigators also looked at heart failure with a reduced ejection fraction with and without diabetes. The Credence trial looked at chronic kidney disease in patients with diabetes. DAPA-CKD looked in chronic kidney disease with and without diabetes. And every one of these trials is reinforcing exactly the same benefits that were seen originally: a reduction in heart failure hospitalizations and a prevention of serious renal events. So now we have 6, 7 large-scale trials with more to come. We've never had this much evidence that is so mutually reinforcing with any class of drugs for cardiovascular or renal disease. So the concordance of this evidence, the fact that they're all showing not only the same effects, but the same magnitude of the effects is really impressive.
All right, thank you for that. And now I have to ask you, when we look at all this data, really the two agents in the class that stand out are dapagliflozin and empagliflozin. Recently, and even at ESC, we saw a Vertis CV analysis. I know some people were a little bit disappointed with the results they saw with erdagliflozin. And there's also, when we talk about canagliflozin, the FDA recently removed it, but there was this concern for increased risk of amputations. When you're looking at these drugs from the perspective of a cardiologist, do empagliflozin and dapagliflozin stand out among this class, or would you still consider these to be, as a whole, class effects with these drugs?
Well, what we're seeing in all the trials, regardless of the drug, regardless of the member of the class, we're seeing the same magnitude of the response on heart failure events and on serious kidney events. Now, each individual trial has its quirks. But that's exactly what you expect when you do clinical trials. You're not supposed to look at clinical trials in isolation. You're supposed to look at clinical trials based on the totality of evidence. So you may look at one trial and say, gee, you know, it would have been nice if that had worked out just a little bit better. Then you look at another trial and boy, you say, boy, that worked out unusually well. And then you realize that both of them deviate from the truth due to the play of chance. Some trials hit a little bit on the low side. Some trials hit a little bit on the higher side in terms of a treatment effect. But we're seeing pretty much the same positive signal across all members of the drug class. Now, if we always have more confidence in drugs that actually have been tested in a specific patient population and has been shown to demonstrate an effect. So a lot of the trials now are with empagliflozin and dapagliflozin, and so we have more data with those two members of the drug class. But when you compare the effects across just empagliflozin and dapagliflozin, they appear to be pretty similar.
So these heart failure and chronic kidney disease are really sort of two of the biggest check marks you could check off the list for cardiologists. What is next in terms of understanding how SGLT2 inhibitors impact the body as a whole? Because it feels like we're really sort of just scratching the surface on that, but we've already knocked off two gigantic concerns of cardiologists with these drugs.
So I think that one way of maybe thinking about these drugs is to imagine that what their potential is in any patient whose hearts and kidneys are under stress. Now, they may be under stress because of diabetes. They may be under stress because of other conditions. They may have chronic heart failure, chronic kidney disease. But you can think of many other disorders that where you might want to apply these drugs. For example, don't forget, we and DAP-HF looked at heart failure with a reduced ejection fraction. There are two large-scale trials now ongoing and will be completed next year in patients with heart failure and a preserved ejection fraction. We're also looking at these drugs in patients who have just recently sustained an acute myocardial infarction or who have asymptomatic left ventricular systolic dysfunction. There's a whole host of opportunities that are present and would be really interesting patient cohorts to study the benefits of these drugs. So hopefully these trials will get done, and we expect very concordant results from these studies, and we're really excited. This is a major advance in cardiovascular medicine.